of their daughter, Maddie, born December 4th, 1998, who died before the age of 7 of a pulmonary vascular disease known as PVOD, or pulmonary veno-occlusive disease. I'd like to quote from their website. It says, quotes, "Our hope is to help spare someone from suffering what we went through and still suffer with to this day. Through the website butterfliesformaddie.com, and with the help of all who visit and take up the fight beside us, we will never stop pushing for answers and a cure for this disease." So again, we would like to thank you, Tony and Donna. I wish I could be there in person and greet you. And we thank you for all your support over the years. At this time, I would like to turn the microphone over to Dr. Erica Stevens to introduce our guest speaker, Dr. Curlin.
Thank you, Dr. Morton. Dr. Curlin originally hails from Baltimore, Maryland. He completed his undergraduate training with a Bachelor of Arts in Biology at Amherst College. He then went on to complete medical school at Stanford University, where he additionally completed his pediatrics residency, pediatric allergy, immunology, and pulmonology fellowship, as well as a combined research and clinical fellowship in both adult and pediatric pulmonology. Following fellowship, he took a position at the University of California, Davis Medical Center. He joined the faculty of the University of Pittsburgh and Children's Hospital of Pittsburgh in 1988, where he currently serves as a professor of pediatrics, director of the Pediatric Flexible Bronchoscopy Service, and director of the Pediatric Pulmonary Transplant Program. He remains very involved in medical education, and I was fortunate to have the honor of completing my pediatric pulmonary fellowship in Pittsburgh under his mentorship. He is a pioneer in the field of pediatric pulmonology with numerous honors, publications, and invited lectures. Dr. Curlin is a leading expert in the fields of pediatric flexible bronchoscopy, childhood interstitial lung disease, and pediatric lung transplant, among others. To give a brief introduction of his talk for today, approaching his 41st birthday, Dr. Jeff Curlin was a busy man. His work as a pediatric pulmonologist, caring for children with lung diseases such as cystic fibrosis and asthma, led to long hours on the wards at the University of California, Davis Medical Center. At the same time, he was in the midst of training for the Western States Endurance Run, which was a grueling 100-mile-long foot race across the wilderness of the Sierra Nevada mountains. His long training runs, the responsibilities of patient care and teaching, and relationships attempting to replace his departed girlfriend occupied most of his life. Dr. Curlin's ordered world is suddenly turned upside down when he is diagnosed with hairy cell leukemia, a rare blood cancer with a low survival rate. His work, his running, and his friendships are altered by his struggle to survive. He finds he must undergo many of the procedures he performed on his patients, must endure surgery and chemotherapy, and must relinquish control of his life to his physicians, surgeons, and his disease. He learns firsthand what cannot be taught in medical school about the consuming power of a chronic illness and its treatment. Confronting his own mortality, Dr. Curlin is now the patient while remaining a physician and runner. With the support of his physicians at the Mayo Clinic, the University of California, and the University of Pittsburgh, he resolves to continue to live his life despite his potentially fatal disease. He discovers his personal inner strengths as well as weaknesses as he struggles to confront his illness and regain some of the control he lost to it. Along his nearly 2.5-year journey, we follow Dr. Curlin as he endures surgical procedures, chemotherapy, and life-threatening complications of his illness. He emerges into remission with new inner strength and understanding of what it means to be a doctor. He also finds that he is still a runner with the same goal, to run the 100 miles across the Sierra Mountains. Please give a warm welcome to my friend and mentor, Dr. Jeffrey Curlin.
Thank you. I'm going to try and share my screen. Erica, you've given my lecture. I'm all done. Okay. Oh, okay. Let me get this into a slideshow. First, before I start, I want to thank you for inviting me here. Can you hear me? Can everybody hear me?
Yes, we can hear you.
Yes, you can hear me? Okay, good. I'm going to try and get this started. I looked over the roster of those who've spoken. I know almost all of them, and I am humbled to be here today. I also trained one of your former speakers, one of my former fellows, Dr. Kumburlis. Finally, before I start, I would like to mention that I read about Maddie, and it's ironic that right now we here are taking care of a young fellow with pulmonary veno-occlusive disease, and we're contemplating soon evaluating him for lung transplantation. I won't be able to tell you the end of that story today, though. So let me start. I'm going to talk about, I call this talk about my own medicine, lessons learned en route to remission. Like with all talks, I have no major financial conflicts of interest, unfortunately. I did write a book, and Erica read from the description of the book. I will have a tangential discussion of off-label drug use, very tangential. Promise there will be no mathematics. And the opinions contained in this talk are my own. And by the way, speaking of what I'm going to talk about, I'm also going to talk about lung transplantation at noon to the House staff, although it won't be about the patient I mentioned. It'll be a general talk, and I hope many of you can come to that also. So I have a few qualifications for giving this talk. I'm a physician, a former long-distance runner. That qualifies me for nothing. I am a survivor, give you a survivor of leukemia, and that's not the only thing I'm struggling with these days, but otherwise I'm pretty well. This is where I work, or this is the city in which I work. This is Pittsburgh, on one of the days when you can see the sun. This little arrow here points to where I work. The hospital is here. It's Children's Hospital, conveniently located, by the way, next to a large cemetery. I'm much more comfortable usually talking about things like lung transplantation, which I'll do at noon. But I think this is an important talk for what I have to say in terms of how one relates to their patients, perhaps what some of your patients are enduring, and how you might make it easier for the two of you, if you will, to think about moving forward together. This is the cover of the hardcover of my book. This is not my hand. The watch is too good. I have a double-headed stethoscope. I have a much better stethoscope than that one. This is I just did a soft cover also, and it's really cheap on a Kindle. So I want to talk about illness, and particularly about my illness. First, illness is the night side of life, a more onerous citizenship. Everyone who is born holds dual citizenship, in the kingdom of the well and in the kingdom of the sick. Although we all prefer to use only the good passport, sooner or later, each of us is obliged to identify ourselves as citizens of that other place. This is by Susan Sontag. If you have not read Illness as Metaphor, I urge you to do so. It's a great book. She's a great writer. She was a great writer. Here's a saying: while there are several chronic diseases more destructive to life than cancer, none is more feared. And this, of course, was said by, well, you don't know who it was said by, but it was said by Charlie Mayo, one of the Mayo brothers, back in 1926, a man well ahead of his time. I'm going to give you a simple story. You've already heard much of it from Erica. I had chest pain while I was running and training for the Western States 100-mile run in California. Unfortunately, the race is over the Sierras in California, so it was very convenient to me in Sacramento. But I had chest pain that I thought I had fractured a rib because I had a cough at the same time. I went downstairs to the radiology, and I didn't need to see a physician. I just walked in there and asked the technician to take a film of me, which he did. And the lungs were fine and the bones were fine, but I had a mediastinal mass, a large one, pushing my trachea to one side. I then I then arranged to get a CT scan, but I did what any normal person would do if they were confronted by something like this. I called my father or my parents. My father was at the Mayo Clinic on the staff, and I knew that if I got treated, I could easily get treated at UC Davis. I mean, they have very good physicians there, but I also knew that as the only active pediatric pulmonologist, as my partner was mostly in the lab, I would be, they'd be assailing my bed, trying to get consults from me while I was trying to recover. So I went to the Mayo Clinic and met Ed Rosenau here, who was a very famous adult pulmonologist, and he saw me in the morning and arranged for a whole bunch of lab tests. Called me at lunch and told me I had to go back in because there was something funny on my CBC. The CT scan, by the way, not only showed the mass, but it also showed that I had splenomegaly. So I had to go back in and have a bone marrow biopsy, and the diagnosis was hairy cell leukemia. He then transferred me my care, or had me meet a guy named Tom Haberman. And then I want to tell you first a little bit about hairy cell leukemia. This was first described in 1958 by Dr. Boronko, who was a Peruvian-born first female chief resident at the University of Ohio, and the first female full professor at the University of Ohio. She was a great hematologist, and she first described hairy cell leukemia. This is why it's called hairy cell leukemia. You can see these little tufts from the ends of the cells, and it stains positive with a trap stain for tartrate-resistant acid phosphatase. And this is what the cells look like. When I was diagnosed, by the way, I had to, the treatment for this illness was pretty abysmal. Splenectomy led to slightly greater than 50% 5-year survival. Leukemia persisted, however. A variety of other treatments were tried, but none were effective, and the median survival was only 2 to 5 years. Anyway, I was referred to Haberman, and he told me when I saw him that if I had to have a leukemia, this was the one to have, it turned out. And it turned out that, as usual, he was quite correct. I was to undergo multiple surgeries, including a splenectomy, over a year of chemotherapy. I had many complications leading to other surgery, and finally went into remission. This is a more recent picture of Tom Haberman. He was a lot younger when this happened, because this started back in 1987, before a lot of the house staff and certainly the medical students were born. That gives away something about my age. That's a pretty simple story, but simple stories aren't necessarily simple. Illness is experienced within a personal context. I had my own set of needs and I had my own personal view of the world. And what I remember is what I choose to remember, I think. And if you want to learn more about why we remember what we remember, I refer you to the books down here, Kahneman's Thinking Fast and Slow, and Lewis, The Undoing Project, which is about the work of Kahneman and Tversky. Kahneman won the Nobel Prize for his work, by the way. So this is my book is highly personal because it's my own remembrance. But hopefully some of the things I remembered are going to be helpful. As Kierkegaard wrote in his journal, it is quite true what philosophy says, that life must be understood backwards, but that makes one forget the other saying, that it must be lived forwards. So I wrote my book 2 years after, or I started to write my book about 2 years after I was in remission. And so that's the way I understood it backwards. But of course, I had to remember how I lived it, which was quite in a forward manner. So I want to tell you some facts about the treatment and some of the lessons I learned that I think you should remember when you deal with your patients. As I said, the long-term survival for this hairy cell leukemia was about 40 to 50%. My physicians then had to decide how to approach my disease. I had a chest mass, I had newly diagnosed leukemia, and were they related? They didn't know. And what was the best or safest approach? It turns out, well, that they were not related. The mass I had was a benign thymic cyst. The very fact that I had the pain in my chest and led to the chest X-ray and the CT scan all had nothing to do with the leukemia directly, but they led to my diagnosis. My physicians then had to decide what was the right thing to do. Should they take out this mass in my chest? They didn't know what it was. And it turned out that the best thing to do was to take out my spleen first and then go back 6 weeks later and open my chest and take out my thymus and to find the thymic cyst, which had nothing to do with my leukemia. During my treatment, I participated in a clinical trial of a new chemotherapeutic agent called pennistatin. It turned out that I found out about or heard about pennistatin as I was recovering from my splenectomy. When my father, the physician, came into my room and had a copy of the latest version, the latest edition of the New England Journal of Medicine, the lead article was on the use of pennistatin for the treatment of hairy cell leukemia, and it was as if to me this was preordained that I would be diagnosed with this disease and a new treatment would emerge. Hopefully, I mean, that can happen for all of our patients. Unfortunately, that doesn't happen for all of our patients. But as medicine moves forward, that will happen more and more. I think this taught me that, among other things, that hope should still be alive, and you should work hard to keep it alive in all of your patients. I was in this clinical trial that was going to start with a course of interferon and then go into pennistatin, and I got into that trial. I didn't have to go into it actually for nearly a year and a quarter after I was diagnosed, because my blood counts, rose quite well just with the splenectomy. But during the interferon, I developed a fever of unknown origin. I had temperatures to 105 and drenching night sweats. My physicians, I was hospitalized here at the University of Pittsburgh for almost about 3 weeks, and they did everything they looked everywhere they could to try and find what the cause of my fever was. I underwent, an LP. I had CT scans. I had nuclear medicine scans, and they could not find the source of my fever. My physicians were convinced it was not my leukemia, but they couldn't identify that source. I finally was transferred to Mayo again, and they also couldn't figure it out initially. I underwent a mediastinoscopy, and they pulled out some lymph nodes in my mediastinum. My fever then went away as if they had taken away the source, and it turned out that those lymph nodes 6 or 8 weeks later finally grew out Mycobacterium avium, which has been the cause of my fever. But my physicians then had to decide if I could then finish the interferon and continue with pennistatin. I watched my physicians as they made these decisions. They were very upfront, very open with me, telling me what the conundrums were, what they were facing, how hard this decision was. I had to trust my physicians and not be one myself. I was often tempted to do that, but I realized that I could not be the physician. I just could be the patient, and I had to trust what they were saying. And the way they made me trust them was to be honest with me. I think that's really important. They had to do this, as I said. I had a bronchoscopy, I had a mediastinoscopy, I had all sorts of stuff done to try and find the cause of the fever, while they're still deciding what they can do about the pennistatin. So what I learned was that some parts of me are indeed strong, but others really aren't. I didn't want to be seen as weak. That was important, but I had to give up a lot to be a patient, if you will. I had to give up being a physician for a while at some point. I learned that post-op pain is real. When your patients are telling you that it hurts after an operation, they are telling you the truth, so treat them. The treatment, by the way, I got for post-op pain was intramuscular morphine. I don't know if any of you have ever had intramuscular morphine, but it feels like you're getting it into your bone, not your muscle, and it is really painful. As a matter of fact, the nurse who gave me my shot at the Mayo Clinic told me that that's why they call it a pain shot, because it inflicts pain and then it takes it away. Anyway, morphine is a great drug, but there are other ways to get it now. So think about that. Learning about procedures by having them done to you sounds great until it actually happens. We always say the famous line is see one, do one, have one done to yourself, and teach one. I don't think that's great idea. But I'm a better bronchoscopist, having had a bronchoscopy. And I learned a lot about it because they do it a lot differently at the Mayo Clinic than I do it. I'll just leave it at that. I'll just say my patients don't have any problems having their bronchoscopies when I do them. You wonder about informed consent. It's nice if you are informed about what you're asking for consent for, by the way. A sense of humor does not hurt. Actually, it's pretty important. My book opens with a joke. My patients bring me jokes, and that helps them get through clinic. The joke I said to my nurse, by the way, she was about to take my temperature, which was about to be 105 again. And I took the thermometer out of my mouth, and I said to her, do you know the difference between oral and rectal thermometers? And she said, no. And I said, the taste is the difference. But anyway, my patients are given an assignment to bring me jokes in clinic. The advantage of that for them is that since I take care of children who have chronic disease, and I see them a lot, and a lot of them are pretty sick, the CF patients, my transplant patients, having to bring a joke to clinic gives them an assignment to take their mind off their disease for a little bit. It also puts them in charge of the entire visit because they start off by them telling me a joke. So they are in charge of the visit. And that I think really helps my patients, and it helps me get to know them. Other thing I learned, mom's chicken soup almost always helped. Certainly my mother's chicken soup always did. One of the things about mother's chicken soup is that it's important that it's made in the same pot. And the pot that my mother made her chicken soup in had been her mother's. And that pot is now the property of my sister, whose chicken soup will almost always help. It also turns out that chicken soup works when the person making the chicken soup for you is someone who loves you, and then it almost always helps. An anonymous ultra runner said, pain is inevitable, suffering is what's optional. So we're all going to have pain in our lives. You can choose whether or not you're going to suffer with it sometimes. This helped me with my running, and it helped me during my illness. I realized I was going to have painful things, but I was trying not to make myself suffer. I learned that signs and symptoms are really easy to miss. I had easy bleeding while I was shaving. I felt tired, more tired when I was running. My easy bleeding, I thought was just that I was on aspirin to take away the pain that I was having in my chest. But it was really because my platelet count was about 40 or 50,000 when I was diagnosed. My fatigue was because I was mildly anemic. I didn't know that. When we are taking histories from patients, we as the caregivers often know the signs and symptoms and ask the right questions and get the obvious answers. And the diagnosis to us becomes relatively straightforward. But you have to realize that most people don't understand the signs and symptoms. And if I can miss them, I realize so can my patients. So be gentle on them when they miss the things that are obvious to us are not so obvious to the ones we're caring for. Sir William Osler was right. The physician who treats himself as a fool for a patient. As I said, I had to decide if I was going to be one of the physicians or whether I was going to be the patient, and I chose the latter. And I have never regretted it. I didn't want to make the decisions because I didn't know how to make them correctly, and I was biased. I know my physicians are going to be somewhat biased, but at least they're less biased than I am. And so I turned it over to them. That was for me a hard decision in some ways, but was certainly the right one to do. As you'll see, I like being in control. You can ask Erica. She'll tell you how much I like to be in control. And the other thing I learned is that receiving a diagnosis leads to brain paralysis. Ed Rosenau, after I got my bone marrow, I went back to Ed Rosenau the next morning. They already had the diagnosis. He sat me on the couch in his office. He pulled a chair up about 1.5 feet away from me. He looked me in the eye and he said, Jeff, that's my name, Jeff, you have hairy cell leukemia. And then he continued to talk. He talked for another minute or two, but I heard nothing, not a word of what he said. All I heard was the word leukemia. And then all I could think about were all the patients I had taken care of as an intern and a resident with leukemia, including ones who died as children, of all the bone marrows that I had to do, all the chemotherapy I had to push intravenously myself into these patients, all the kids walking around the hospital with no hair from their chemotherapy. That's all I could think about. I heard nothing of what he said until he told me that he was going to introduce me to Tom Haberman, and then I sort of came back down to wherever I was to follow him to where Dr. Haberman was. But when I give a diagnosis now, especially a diagnosis like cystic fibrosis, I tell the patients and parents, I tell the parents in advance that they're not going to remember what I say. And I warn them of that because that's right. And sometimes I tell them, I'll tell them again. I'll tell them the same thing several times so they will hear it and understand it. People hearing bad things may not hear any more after they hear the bad thing. And I think we all should remember that when we take care of our patients and their parents. This is from a song by Jackson Browne from his probably best album, or one of his best albums, Late for the Sky. Don't know what happens when people die, can't seem to grasp it as hard as I try. Like a song I can hear playing right in my ear, I can't sing it, I can't help listening. I knew about leukemia when I went into this, but then I realized I knew very little about it. I learned that recovery from anything in medicine obviously requires a lot of patience. I'm not a very patient person, but I had to learn it there. I also needed encouragement from my physicians, my family, to be patient as I got better. I found that illness is both isolating and painful and demoralizing, and I felt terrible at times. But I was also able to focus on getting better, and it could be uplifting and somewhat enlightening in a way. I can't explain why that is, but as I was going through my chemotherapy, as miserable as it made me feel, because I had, with pennistatin, I had overwhelming vomiting, and I would miss 3 days of work every time I got it every other week. But I felt stronger as I was going through this, slowly but surely. When I was in the hospital, I didn't want people to come in because I knew I'd look terrible, and I would rather not be seen as weak, even though I put on whatever show I could when I was making rounds in between chemotherapy to show that I was still strong, but I knew that I really wasn't as strong as I could be. I learned that physicians don't always know the answers. I mean, Haberman didn't know what to do about the splenectomy versus thymectomy. He called around the country. After I was diagnosed, he called several other experts in hairy cell leukemia and asked their opinion on what we should do first. He knew to look for answers, and he told me about this. He told me the people he called. I really admired him, one, for admitting that, and two, for telling me. Don't be afraid to tell your patients and families that you don't know the answer. But do tell them that you can always try to look for it. Like I say, honesty, full disclosure are good policy for physicians and certainly for patients. I had to be honest about how I felt when I had fever, when I was ill, what I could do and what I couldn't do. And I had to be honest with myself about that. The patient-physician relationship is fluid. It's built upon compatibility and communication, I like to say. I was able to talk to Haberman very well, and also to my physician here in Pittsburgh who took care of me, Larry Ellis. We all became very close during this entire time. I felt I could call them and talk to them, tell them what I was doing, and ask for their advice. The ability to listen enhances one's ability to communicate. That goes for patients as well as physicians. So we have to learn to listen to our physicians, and our physicians have to learn, or we as physicians have to learn to listen to families and children, since we're pediatricians. I just put and maybe for these polarized times, we could each benefit from listening and communicating, just to mention that. But I certainly learned that this is a really important factor in the patient-physician relationship. This is a note written by one of our transplant patients. She was about 2.5 or 3 years out from her transplant. She had a really rough, unfortunately bad go of it, and was in respiratory failure or close to it at this time, on a ventilator now, and was in the process essentially of dying. And she wrote this on a piece of paper where it says, "You docs suck when it comes to communication." That's, I mean, I knew what she was saying. And we hadn't communicated well enough with her, obviously, not to her liking, and she made no bones about it. And I saved this to remind me that one of my jobs is to communicate as best I can to all my patients when they're both well and when they're sick. There are, of course, different coping strategies for dealing with sickness and with friends who are ill. And there's a whole bunch of books on non-traditional medicine and related topics, and the psychology of disease and all that. And a lot of my friends, when I was sick, a lot of them sent me books on non-traditional medicine, and I didn't read any of them. I read none of them because I was too busy trying to figure out modern day medicine and what it was doing for me. So I'm going to now switch and talk about, well, how do you get through illness? And essentially, what do you do? What was I doing? You have to realize that walking through the fire changes the person doing the walking, and also changes the people watching and supporting the person doing the walking. I had nearly 2 years or so of walking through the fire, if you will. And it changed me as a physician, and changed my family. It may have changed my physician, but it certainly changed my family and my friends. Susan Sontag, again, in Illness as Metaphors: theories that diseases are caused by mental states and can be cured by willpower are always an index of how much is not understood about the physical terrain of disease. I'm not sure that's completely correct, but I think a lot of it is correct. And by the way, if you read Illness as Metaphor, she was ill at the time that she was writing this book. I won't go into any more detail, but it's a really good book to read. Bernd Heinrich is a naturalist, a biologist, who at one time was the American record holder for the 50-mile run. This is a photograph of him. He wrote a book, Why We Run, and I'll just highlight this saying here: we can't cure cancer with good thoughts, but good thoughts can make us feel better and allow us to function more effectively. So yes, there's a mind-body connection, but there are, as he puts, there are limits. Even Hippocrates said, prayer indeed is good, but while calling on the gods, a man should himself lend a hand. So you can think about calling on the gods, but if you got medicine, my advice is use it. Well, to a large extent, I found that all these lessons I learned were somewhere already within me. My experience that I went through reinforced many of the tenets that actually had shaped my life as a physician. And before that, a runner. I was a runner well before I was a physician. And only recently have I stopped being a runner because I'm an old man with knees that have seen many, many hundreds and thousands of miles on the roads. So one of the things I learned when I got my exam initially by Ed Rosenau, he listened really carefully to my symptoms. I teach a course in advanced pediatric interviewing to 2nd and 3rd year medical students, where they get a history in 20 minutes from one of the other students who is assigned a disease. They don't have any lab findings, they don't have an exam, they don't have any radiographs, but just with a history, they're to come up with a differential diagnosis. So this is a saying by Sir William Osler: listen carefully, the patient is telling you the diagnosis. And I saw how carefully Rosenau and then Haberman listened to me to get an idea of what my symptoms meant. Honesty is always accepted. It's always appreciated. And I learned that I took real advantage of my medical team in the sense that I listened to what they were saying, what they were learning, how they were making decisions about me. And I think we owe it to our patients to give them that same advantage. If they know what we're going through to help them, they may understand, one, that what we're doing is hard work. Two, there may not be easy answers. And three, we're all on the same page. We need all of us to recognize that medicine is always changing, always improving. And this is a constant thing that goes on in medicine. And it should be expected, not just by us, but by our patients. And a good example of that is what's going on in cystic fibrosis now. A year and a half ago, we were telling our patients we were getting a new treatment. And we now have that new treatment in the form of Trikafta, which is maybe not a wonder drug, but it's a doggone good drug for CF. And it's changed the lives of so many of our patients, so many of my patients. So we should listen to our patients about their diagnosis and talk to them honestly about what they have and their prognosis. Our patients have to listen to us, but they have to talk to us. We have to listen to them. We want to know how they're responding to their treatment. Ask them what their fears are, their needs, their goals. Everybody has a goal. Even a 6-year-old patient may have an easy goal. And if you know what it is and can relate some way to it, that will empower your patient of whatever age and their parents to carry on in the work that they're doing. None of us do this willingly. I certainly didn't choose to have leukemia. I wanted a good outcome, but as I showed you at the beginning, my long-term prognosis was not that good. But a lot of surviving an illness is maintaining a quality of life. So what is quality of life? I'm paraphrasing Justice Potter Stewart in the case of the obscenity trial, Jacobellis versus Ohio, 1964, where he said this is about pornography in this case. I can't define it, but I know it when I see it. This is not a direct quote because it's something between I can't define it and then a bunch of other words, but I know it when I see it. I know what quality of life is for me. For each of your patients, it may be a little bit different, but that's the key for them and for you in each of your patient interactions. This is what's really important. Like I knew as a doc, I had control over my life and for that matter, some of the lives of my patients, if you will. I mean, they had to take their treatments. My CF patients had to do their best treatments. They had to take their vitamins. They had to take their enzymes. They had to come and see me. They had to do their PFTs, all these things. You know, as a patient, I was at the mercy of my illness. I had to take time off of work every time I got my chemotherapy. For a weekend, I was out of commission every 2 weeks. It really sought to control or actually take my life. And I was thinking about it all the time, even when I was working. So you want to take control. The question should not be what's the matter with you. It should be what matters to you. You should ask this of your patient. Yes, you know what matters to them, what's the matter with them, but what matters to them? You know what's the matter with them. So what matters to them? For me, what mattered? Well, I wanted to work, and I was still able to work in between chemotherapy. I was single when I moved to Pittsburgh. As you will see, it was a pretty crazy time, but I eventually found the woman I'm married to. And running, maybe not in this order, but running was central to my life. I talked with Haberman, and he allowed me to run up to 4 miles a day. That was the most he would let me do. And that sounds like a lot, but 4 miles, trust me, for me was, that was a fairly light run, but I was at least allowed to do that. My work has taken me to several places. This is Stanford. Back when I was there, this fountain was in the middle of a parking lot. This is UC Davis. This is the Children's Hospital, is the white building in the middle of all these other buildings, most of which are the University of Pittsburgh Medical Center. And now you already saw this is the new Children's Hospital. So my work has always been important to me. And as Osler said, I desire no other epitaph than the statement that I taught medical students in the wards, as I regard this as by far the most useful and important work I have been called on to do. And I feel the same way. I like teaching. I do my best. I don't always do great, but I do my best to teach those who are working with me, to encourage them to learn more and to do more. And you can ask Erica if I succeeded in that at all. Also, I had the secondary craziness of disease. I was single and alone, and I did some really crazy stuff. And my life reflected that. So I'd been in remission almost 2 years before I finally met the woman who I married. And this is us in Buenos Aires. I went there to give some lectures, and we had a little bit of time on our own. I'll show you another picture of her in just a minute. But it's running in my disease that was important. My dad, who was an epidemiologist and a very famous one, asked if running caused my leukemia. Haberman said no. Did running, on the other hand, make me strong enough to withstand leukemia? I said, well, maybe. Did running allow me some level of control to get through leukemia? And to that I say, absolutely. I was given something that I wanted to do in the face of disease. And my physician was okay with that. And that allowed me to have the control that I needed to get through the disease. Think about this when you're dealing with your patients. Same thing holds. They may not want to run 4 miles, but they have other things they want to do. Listen to them. Whoops. My definite goal was the Western States 100. And so this is the course of the Western States 100-mile run. It starts here on the far right, Squaw Valley, which was the site of the 1960 Winter Olympics. It goes up and over the Sierra Mountains and ends way down here on the left at Placer High School in Auburn, California, on the other side of the Sierra Mountains. It's almost all trail. It's almost all rugged trail, and there are things like snakes and every once in a while a cougar. Some people have been killed in training, by the way. There are cougars that are wild in these mountains. This is an elevation profile. If you start on the far right, this is the elevation here is about 6,400 feet. You go straight up the first 2.5 miles about to almost 9,000 feet. And the rest of the races you see is a net downhill. But you have approximately 18,000 feet of uphill in here. And some of these uphills are extremely steep. You can only walk the uphills. But there's nearly 23,000 feet of downhill. And any of you who are long distance runners or have run a ways, you know that the uphills make you tired, but the downhills hurt your quads and they just trash your legs. So that's what I had to go through. This is what it looks like. This is about 20 miles or 18 miles in. I'm wearing a white hat and a white shirt. At the start, the race, it's about 35 degrees. It'll hit about 105 degrees in the mountains in the summer when this takes place. So the white shirt is to reflect the sunlight. There's a little blood on it you can't see, but I've already fallen once on the course. I flattened out and hit the dirt. I'm carrying water here, and I have a belt that has 2 more water bottles. Or this is not just water. There's some Gatorade or something, electrolyte fluids in there. So you carry your own fluids. At the aid stations, you can refill, but there's nothing in between. And this is what it looks like. It's all trail. I'm going up to a place called Cougar Rock. This is as steep as it looks. It's actually steeper than it looks. There's a river way down here in the distance, and we're going to see that in a minute. That's the American River North Fork at 80 miles. This is still in the 20-mile range. This is going across the river. These are the lucky people who get there early. These are the lead runners. This is 80 miles. They started at 5 in the morning, and it's still light. The really crazy people are the people here who are holding this cable across the river. Notice there are some boats in the back. The first time I ran it, there was a cable. The second time I did it, I'll show you that, the water level was so high we had to take boats. But you have to walk across the river, and I got to the river in the middle of the night. It was about 1 in the morning. I'd been running since 5 in the morning. I was exhausted. And the people here would carry lights, had lights on, and they would show me which rock to step on for each footstep across this river. I finished in just under the allotted 30 hours they give you to finish. I was not very pretty and not very fast. I have a pacer who's a neurologist. My father is here on the far left, the one who asked if my running had caused my leukemia, but he and my mom were there. They didn't make it to the start because my dad was never on time, so he missed the start, but he made it to the finish. Anything someone is stupid enough to do once is probably worth doing a second time, so I did it again 15 years later. This is Al Leon, one of my friends, and now this is my wife. I'm about to start. It's about 30 degrees. I'm going to take a lot of this stuff off because it gets really hot at the end. The difference between this race and the first time was this time the course was the first 25 miles of the course were through snow. The snow was up to my calves, sometimes up to my knees. I have different outfit on. This is about 30 miles. This is my wife waiting for me at the 92-mile mark. Notice it's completely light. By this time, the people who have won the race have finished it, had dinner, had a shower, had a night's sleep, and now they're getting up. And I was still at the 92-mile mark, had 8 more miles to go. But I managed to make it under the 30 hours, as you can see, not by much, but I ran a better race despite those 25 miles through snow. But I want to look back lastly at some of the ethics and ironies I encountered. Informed consent is nice, but communication counts for a lot more. When I was at the Mayo Clinic, I never signed a consent form for my surgeries, for anything. I never signed they didn't come to me for a consent for my bronchoscopy. I didn't sign a consent for my bone marrow. I didn't do any of that, but they talked to me. And is informed consent possible? I would say I'm not sure about lung transplantation. If I told everybody the complications of lung transplantation, I'm not sure they would want to have it done. How about a diagnosis with no known cure if you're going to do a procedure? Is that worth doing? These are all, I'm not sure informed consent is always possible. Sometimes it's difficult to get it. Sometimes it's difficult to prove the effectiveness of therapy. And that's really important. I got experimental therapy at the time. I was on a research project, a protocol. Should every treatment be proven with randomized controlled trials, and like evidence-based medicine? And a lot of us, I think, would agree that that would be really good. And I think that's pretty much an established fact. However, that can't always be the case. I mean, here, for example, an article in the BMJ in 2003, parachute use to prevent death and major trauma related to gravitational challenge, a systematic review of randomized controlled trials. And it turns out there had never been a randomized controlled trial to test the parachute. So they said that advocates of evidence-based medicine who criticized the adoption of interventions evaluated by using only observational data were out there, and they thought that everyone might benefit if the most radical protagonists of this evidence-based medicine organized, participated in a double-blind, randomized, placebo-controlled crossover trial of the parachute, just to see if it really works. I think you know where we're going with this. That was in April, I think, of the BMJ. A few final thoughts I'll leave you with, because we're getting close to the end. The physician should not treat the disease, but the patient who is suffering from it. Moses Maimonides. And since he was partly a pulmonologist, this was his treatise on asthma. And I think he had a lot of insight. He didn't have any theophylline back there or anything. But in his case, treating the patient who's suffering and looking at the patient first, not the disease, is important for all of us to do. It's easy to see a patient as a case of CF, or a patient with, somebody, a BPD patient, or a former preemie, or a leukemic. They're people first. Our patients are people. Their families love them, and we should treat them as we would treat our own kin, and respect them and their families. This is easy to say, sometimes hard to do, but try and keep it in mind. Human decision-making, and particularly decision-making in the face of uncertain, inaccurate, and imperfect information, remains absolutely vital to the life of medicine. I experienced this because my physicians had to make difficult decisions without adequate data. And as one of my former mentors told me, 50% of all medical decisions are based on insufficient data. You can always get more information, but at sometime in a patient's course, you have to make a decision and realize that what you have may not be complete data, but it's what you have to go on, and you have to make a decision. This is really difficult, and I watch my patients, my own physicians go through this. I have to make decisions like this, unfortunately, all too often because I'm in the business of lung transplantation, and you'll hear about that at noon today for those of you who make it. But this decision making in the face of imperfect information is vital to the life of medicine, because one, that's the way we have to treat our patients one way or another. And the other reason is that we have to learn from what we do. I have another slide which I didn't include, which asks the question, how do you get good clinical judgment? And the answer to how do you get good clinical judgment is by experience. And then the next question is, well, how do you get experience and gain experience? And the answer is, well, bad judgment sometimes. But you have to learn to make decisions. Those of you who are in training, sooner or later will be out there calling the shots. And I know that what I had to do, one of the hardest transitions I had was going from a fellow to being a faculty member. I'm hoping that Erica is doing a good job of it, but I can understand the difficulty because I remember being a fellow and being able to look over my shoulder at my mentor and say, was that the right decision to make? Only now, when you become the attending, they're looking at you to make the decision. So this is really important. By the way, this book by Siddhartha Mukherjee wrote the book, The Emperor of All Maladies, about cancer, and he wrote a book called The Gene. Both of those are 500 plus pages. They're very long. The Laws of Medicine is about 80 pages. If I could recommend 2 books to read from this talk, one of them is The Laws of Medicine. It is a great, short, concise book about some of the laws that he has come up with in his training. It's absolutely brilliant and very well written. And the other might be Susan Sontag's Illness as Metaphor, although it's sometimes depressing to read, I have to say. The true mystery of the world is the visible, not the invisible. Oscar Wilde. We see it in front of us every day with our patients. They're part of the mystery and the wonder of the world. It is our good fortune to be able to care for children. We band of brothers, as I like to say, brothers and sisters. I'll put it that way. Better yet. But we have the opportunity, the honor, the responsibility, and sometimes the difficult world of being able to care for patients who are often young, often sick, and often with diseases that need a lot of care. We're also caring for their parents. Keep that in mind when you meet with them. Remember the lessons that I learned about communication, about humility, about what they are going through to some extent. Don't ever tell somebody you know what they're going through, though, because you will never be able to really know what someone else is going through. But you can have sympathy, not necessarily full empathy, but sympathy for what they're going through. And I think with that, I will stop. And if your mentor, if somebody there wants a copy of these slides, I'm not sure if they're worth it, but this is my email. And I think I finished on time. I thank you very much for your attention. I don't know if there are questions or how I do this. I just will stay here and wait. Thank you.
Dr. Kurland,
Yes.
I think you've done a wonderful job of encapsulating the potential gifts of being a pediatrician, a provider, and a wonderful landscape of the potential we have of how to deliver great care to ourselves and our patients and their families. It's a fantastic lecture. The essence of everything that you've given should be rethought about and listened to again and again. Thank you for a great lecture.
Thank you so much. And thank you very much for inviting me. I wish like everything I could be there in person, in part to see you all. And also, it turns out my brother and sister-in-law live in Louisville, and my niece lives there. But I thank you all very much for inviting me. It was really a pleasure. And I'll see a lot of you at noon, I hope.
Dr. Curlin, this is Ron Morton. I'm the pulmonary division chief, and I wanted to thank you for your talk. I filled up my Amazon cart with a lot of the references that you gave us. So
Thanks. Great.
hopefully we can meet in person at ATS or CHEST at some point.
Yeah, probably won't be ATS this year, but hopefully soon. I hope.
And thanks again for your mentorship of Erica. She's a really top-notch addition to our division.
Well, I'm very happy to hear that. I knew she would be. She's a star. Thanks, Ron.
Thank you.